Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Mr. Jordi Sanchez-Ballester from Liverpool, United Kingdom. Mr. Ballester is a consultant orthopedic surgeon based in St. Helens and Knowsley's Teaching Hospital and NHS Trust, respectively. He specializes in foot and ankle surgery as well as knee surgery and trauma surgery. Mr. Sanchez-Ballester was trained in Barcelona, Spain, where he's from, and he completed his postgraduate studies in London and Manchester. Mr. Sanchez-Ballester is a fellow of the British Orthopedic Association and member of the British Orthopedic Foot and Ankle Society and British Association for Surgery. He has many publications in his areas of expertise and is also an honorary senior lecturer at the University of Liverpool. Alongside his surgical and clinical commitments, Mr. Sanchez-Ballester is member of the Examiners Panel of the Intercollegiate Specialty Examination in Trauma and Orthopedic Surgery and has been the clinical director for trauma and orthopedic surgery at the St. Helens and Knowsley Teaching Hospitals from 2013 to 20. If you notice, Dr. Ballester has delivered several lectures on our channel and it's already reached a huge audience. And today is my great honor to bring back Mr. Jordi Sanchez-Ballester for this wonderful live program. Over to you, Jordi.
Thank you very much again for inviting me to talk in your site. Today, we're going to talk about ankle arthritis, end stage, and the main question will be, do we fuse it or do we replace it? So here's a bit of a summary of what is my talk about. I'm going to talk a bit about epidemiology. I'm going to leave the mechanical properties and the non-operative treatment for another talk. And I'm going to talk only about the surgery for end-stage osteoarthritis of the ankle. So talking about the epidemiology, we need to realize that ankle arthritis is not the same as the same as hip or knee replacements and arthritis. It is clearly less common. It is a procedure that we don't normally do as much as a normal arthroplasty surgery for the knee or for the hip. You can see here in this paper in 1992 that the total knee replacement are performed 24 times more than an ankle arthrodesis and arthroplasty together. In St. Helens, which is our hospital, we cover about 400,000 inhabitants, and we are 3 foot and ankle surgeons. And in a year, we do 28 ankle fusions between all 3 and 7 ankle arthroplasties. Compare to the same unit, the same population, we do 600 hips and knee replacement per year. So it's clearly, we're not talking about the same type of volume and type of arthritis that we normally discuss hips and knees. So also the BOFAS, which is the British Orthopedic Foot and Ankle Society, recently has accepted that approximately 29,000 patients are referred to the hospitals with ankle arthritis annually, but of those nearly 30,000 patients, only 300 are advised to have surgical intervention. So it's a very small volume. And the final treatment for this type of pathology is given based on the surgeon's experience, just pros and cons of each option. Also, the patient activity is important to value, and the medical comorbidities. The fact has been accepted is that there is no good quality evidence to correctly advise patients for this type of either arthrodesis or replacement. So, as I mentioned before, end-stage ankle arthritis, there is only these 2 options from surgery point of view, which is the ankle arthrodesis, which we can do it arthroscopically or open, and also ankle arthroplasty. Having said that, still on this day and age, ankle arthrodesis is considered the gold standard choice for end-stage ankle arthritis. What indications do we have for offering to a patient ankle arthrodesis? So end-stage arthritis, as I said. These two in red, I'm going to leave it for now, and I'll come back to it. Then there is as well the severe deformity in arthritic ankle, which is more than 15 degrees, non-congruent, neurological deformities, patients that they have had an arthroplasty surgery that has failed, and at the same time, an open reduction internal fixation for fracture that has failed. So these are probably indications that most of us foot and ankle surgeons will agree. The high level of activity and the age is probably a relative indication or contraindication, and I will talk about it in a minute. So we said the indications for fusion. So what are the indications for ankle replacement? So again, in white is what most of the surgeons will agree, that ankle replacement can be done for a ankle arthritis that is very well aligned, is less than 10 degrees of deformity, is stable, the talus is good bone stock, no signs of osteoporosis or osteonecrosis, and as well, very important, if there is multiple joint involvement, meaning by that subtalar, choppered joint, patients that they probably like rheumatoid arthritis, inflammatory joint disease, that they will get benefit from some movement, and that's why ankle replacement is quite advisable. So the relative contraindications are those indications that I think, depending on the surgeon that you will discuss, the options will give you one or another. So younger than 60 years old, generally is advised that arthrodesis is better because there is a higher risk of revision in younger patients compared to olders, but not every surgeon will think the same way. Previous infection, severe lower extremity malalignment. It is possible to do osteotomies in the calcaneum, in the distal tibia, to be able to accommodate an ankle replacement and therefore correcting the deformity. As well, there is a, I'm sorry, I'm gonna charge the computer because it's going, sorry, it's charging again. So there is a marked instability. There is another risk that some surgeons will advise to do an ankle replacement, repairing the ligaments and reconstructing the ligaments, but some others will feel that fusion is much more reproducible. An osteoporosis or osteonecrosis of the talus is, again, another relative indication or contraindication. Arthroscopic ankle arthrodesis. This is done as a day case, and generally speaking, is a very good procedure. It has got excellent outcome in terms of fusion. You can review different papers, but the average union is considered to be 94%. Very few soft tissue problems, very few infections. Is really quite good procedure, and is discharged the same day. So there is no, even in an all patient group, there is not much disturb of the life. So coming in at the case, they go home, and probably the only thing is the first 6 weeks needs to be non-weight bearing, but even so is quite acceptable. There is the open arthrodesis, which is mainly offered to severe deformities that an ankle arthroscopic procedure cannot really correct. And I normally use it through the transfibular approach, which it gives you a good bone graft from the fibula. Again, the results are quite good. Average is probably slightly less fusion rate than in an arthroscopic procedure, but it's very, very high. 89% is accepted to be a reasonable number to discuss with the patients. Certainly, it's got more risk of having infection in the skin, soft tissue problems, difficult to be done as a day case, although in some occasions we've done it, but it's less common nowadays. I think it's important to explain that when I have a patient that I think fusion is the best option, I think very carefully why I cannot do it arthroscopically, because that's my first option. If I can see that it's too deformed or whatever reason, I think then we do the open, but otherwise I'll always offer the arthroscopic procedure. In terms of mechanics, so the biomechanics of the ankle fusion, it's been shown in the past that because the joint is stiff, the joints around, they need to have some extra movement and some compensation to have the joint above completely fixed. And that has shown as well and has been suggested in many papers that produces arthritis in the joints around the ankle. And that normally occurs after about 7 years. And certainly the function of those joints around the ankle is got some biomechanical disturbance compared to an ankle replacement that is got much greater arc of motion, and there the joints around are kept quite biomechanically the same as before the operation. So it's got some negative effects doing an ankle fusion, and that's why ankle replacement is becoming more popular and is slowly being done in more hospitals. Having said what I explained so far about the function, there is as well some studies that, although it's clear that the function in the foot and hind foot is different comparing ankle replacement with ankle fusion, this is not really passed to the clinical ground. So we see that in about 7 years, in this study that I quote here, they've got 4 patients out of 52 that are needed a subtalar fusion in 4 years. And some of them they've lost in the follow-ups, but there is no deterioration on the functional scores. And although there is a degree of radiographic degradation of the subtalar joint, that doesn't really get reflected on the clinical symptomatology. And this is a study that I have quoted here, is a study that is looking at patients at 7 years after the surgery and then after 23 years. So this is a long study, and the functional scores are not really changing very much during that long period of time. So although certainly the biomechanics are not the same, the function and the functional scores mainly for patients doesn't really change very much for a long time. So going now and talking about ankle replacements, ankle replacements, they have had a bad reputation for a long time. And they were initially, and when I'm talking about a long time, I'm talking about maybe in the 90s, early 90s, 80s, there were poor initial results, significant wound problems, persistent pain at the talofibular joint, and there was a poor ankle dorsiflexion. So the gait kinematics and kinetics was not shown to be really very, very good. And that's the bad reputation of the ankle replacement. There was a second and third generation introduced in 90s and 2010. Probably the most known ankle replacements of this period is the STAR, buccal papas, and the mobility, which are shown on this picture. That the beginning of the real acceptance of the orthopedic community of ankle replacements probably started with this paper by Peter Wood and Sue Dicken in Wrightington in 2003. They looked 200 STAR ankle replacements, and although they were mainly patients with rheumatoid or inflammatory joint disease, there were some as well with arthritis. And they showed that at 5 years, there was a success rate of 92.7%. So it was really a very, very good outcome, and with time to decision to revision of fusion as an endpoint. So that it was a paper that encouraged all the foot and ankle orthopedic surgeons to try to start doing ankles instead of advising fusion. There was some other study that, although Wrightington is a hospital, is a tertiary referral center with large volume of patients, there were some other papers at the same time of a small volume centers. There was 4 different centers that they amalgamate 59 total ankle replacements within 4 years. And they showed, again, a slightly less than in Wrightington, but the survival rate was about 86%. So that is reasonable compared to the previous results. There was another paper that they tried to do a systematic review of the literature just to really be able to show to the public and to the orthopedic community what is the reality of all these findings doing an ankle replacement. And although they showed that some studies showed a small revision rate at 5 years, there were some others that they showed significant revision rate, which it goes up to 32%. They also showed that all the papers they reviewed, there was a small change in the pre-op range of movement compared to the post-op range of movement. Also, deep infection, there was a degree of variety in the reviewed literature. From some papers, no infection at all, and some others in the superficial 14.7%, and on the deep to 4.6%, which is a big variety. Also, they showed that there was some progression of osteoarthritis of the surrounding joints between 15 to 20%, with increased radiolucent lines during that period of time of between 15 to 30%. There was also a residual pain in the hind foot, again, big variety. Some studies only 2%, to some others nearly a third of the patients. Return to activities like sports or hobbies, they were only seen in probably 50% of patients, and those activities were hiking, cycling, swimming, which in a way is not the greatest of the results that we will expect. So during all this period, we're talking about late 2000 and early 2010, then, although the mobility ankle was the ankle that, following Peter Wood paper and his design, because mobility was designed by Peter Wood, also Repstein in Switzerland. that ankle was thought to be the best ankle, and it would take us to the next level. In 2014, that ankle was withdrawn for the market due to increased revision rate. Also, looking at during that same period of time, the Swedish ankle register with a 20 years follow-up, it showed that the START ankle replacement, which is the ankle that was published with very good results in writing in 2003, it showed that the outcomes were not really as good as were thought to be, and there was really more revisions than expected. Also, it showed that a woman had a statistically higher risk for revision than men. And that was published in Foot and Ankle International in 2015. Following the withdrawal of the mobility ankle replacement in 2014, it was introduced the Infinity prosthesis, which is a uncemented prosthesis with a fixed bearing. And this, at the moment, seems to be the ankle replacement that is chosen by most of the surgeons. Still not long-term results, but most of the units, at least in the UK, are using the Infinity, although I'm sure there are some other ankles that are used elsewhere. There was some early results of the Infinity, which showed generally good results. So a follow-up between 2 to 4 years, it showed survival rate of about 67 ankles of up to 97%, and with very significant improvement of the function. So that makes our all think that the Infinity was the right way forward. And most of the surgeons that we were using mobility, we moved to Infinity. However, later on again, the same problem occurred, and although there is some other papers that they show reasonable results, this paper looking at 159 ankles with Infinity arthroplasty at 20 months, there was at 13 months was already 10% revision rate. So most of the problems was due to a symptomatic tibial component loosening and deep infection. And also on the first year, it was shown about 7 to 8% of global lucency around the tibial component, which is not what you expect after so short period of time. So now we've got that Infinity, as I said, is still probably the most used ankle replacement at the moment, at least in the UK. But there is different ankle replacements, which is the 4th generation, which are used very rarely for primary, although sometimes it is used for primary, is used for revisions most of the times, or if this done as a primary in cases with significant bone loss and patients that they need some stem to create some stability. But again, this new generation of 4th generation still very early, so there are not many results to confirm if it's good or not procedure. So because all these different issues with ankle replacement, that the results are not as good, also the lack of function with ankle fusion. There's been some meta-analysis done and shown that, well, looking at the ankle replacement or ankle arthrodesis, The short term is very similar. The satisfaction and an intermediate or short term as well is very similar. The implant survival rate overall in the meta-analysis carried out for ankle arthroplasty is 78% at 5 years and 77% at 10 years, which is significantly lower than any other arthroplasty in the lower limb, like the hip and the knees. So again, looking at the total ankle replacement versus ankle arthrodesis, there is another study in 2010, which the total outcomes in one or the other group are very, very similar. But probably the arthroplasty group showed a bit better in terms of pain relief than an ankle arthrodesis. However, as well as they had better pain as an outcome, they had as well more complications and more revision surgery, the arthroplasty patients. Also, what is important to realize that if you are going to advise a patient to undergo an ankle replacement, if it fails, then what will be the next option? As I said, the next option will be perhaps to do another ankle replacement with a 4th generation prosthesis, which is still, we don't know how it's going to be the results, but also traditionally it's been offered to have a salvage arthrodesis. And it is very obvious in the literature. I just quote one patient, but is generally, that's what the literature shows, that salvage arthrodesis leads to impaired quality of life and reduced function combined with significantly higher pain compared with primary ankle arthrodesis. So that is important for a patient that is going to have an ankle replacement to know. This is, for example, one of the procedures that are done if an ankle arthroplasty fails with a degree of lack of bone. So we need to put cage with bone graft to keep the length. And certainly this is a high complication rate procedure. And that's why the salvage procedures are not as good as a primary arthroplasty, sorry, primary fusion. So this is another paper showing the compare total ankle replacement with ankle arthrodesis at 2 years, which it shows that at 2 years the revision rates are not big difference between one or the other. The older age is a predictor for a lower revision risk, so therefore that's why a younger patient less than 60 years old is probably not the best advice to have an ankle replacement, and men had a higher revision rate than women. And that was published very recently in 2022. Looking at per country, I talked about Sweden before. Now Germany. Germany is been, if you look at the progression on the procedure done for end-stage arthritis, looking at this graph, is clear that in 2008, on this graph here on the left, the numbers of procedures for ankle arthritis increase. However, the joint replacement of fusion was very similar. However, from 2009 downwards, if you look at Germany, the number of ankle fusions have increased significantly, and the number of ankle arthroplasty has decreased significantly. So that probably means that the surgeons in Germany are feeling that the results that they're getting from ankle replacements are not as good as they expect, and that's why they advise to have fusion in their patients. So to be able to know for sure what is the best option to give to patients, there's been some attempts in the UK. There is a multi-center randomized controlled trial, which is called TARVA, which is 16 centers involved, and the aim is to recruit 164 patients in each group, ankle arthroplasty in one group, ankle fusion in the other, and the patient age group will be between 50 to 85 years old, and therefore assess what is the best advice to be given to the patient based on this study. This as well, another similar study set up in Canada, but still we don't really know the long-term results. So in summary, when we're talking about ankle arthritis and a stage, total ankle replacement or ankle arthrodesis, the facts are that the ankle arthrodesis remains time-tested. Ankle arthrodesis is reliable, cheap treatment for ankle OA. It's certainly total ankle replacement is got better biomechanics, however, has not proved so far better outcomes. Revision surgery to ankle arthroplasty produces not a really very good outcomes. There is a higher failure rate over time with total ankle replacement, and that is what at the moment is the literature showing. So therefore, there is very little evidence to suggest that total ankle replacement is superior to ankle arthrodesis. And I think this is fair to explain to patients when consenting for an arthroplasty surgery. So there is future trends. The future trends are to be able to answer some questions. And the questions that we really need to find out is, will functional outcome of the arthroplasty surpass clearly the arthrodesis? Will the motion of the ankle that we will keep doing arthroplasty surgery prevent subtalar arthritis? What will be the survival rate of the new ankle replacements in short and long term? And will these multi-center trials answer those questions? This is something that we need to wait and see, but hopefully soon that will be answered. Many thanks.
Thank you, Dr. Ballester. Dr. Ballester, you can stop sharing.
Okay. Stop sharing.
Thank you, Dr. Ballester, for this evidence-based presentation. Few questions, Dr. Ballester. Now, Dr. Ballester, do you think over a period of time with better implants and understanding of the biomechanics, ankle arthroplasty would equal that of a total knee or a total hip? Because your JBJ's latest paper 2022, the results are much better, right?
Yes, I think this is the aim, and I hope that that will happen. I think the technology and the multi-center studies will try to improve and give us a bit more guidance of what to do. But the fact is that at the moment, there is the only thing I can look at in what is the evidence is that we keep thinking that the new ankle will be better than the old one, but then a few years later, that doesn't happen. So I'm not sure why. I think the ankle joint is not the same as the hip or the knee. Perhaps as well because it's small numbers. Surgeons we're not getting used to do it, and the answer will be to be done only in small centers that one or two in every region do it, and then they'll be able to get more numbers to be able to get better at it. So I'm not sure if it's just a combination between lack of surgical skill or lack of technical capacities, or maybe the ankle joint is a difficult joint to replace. But hopefully will get better in the future.
And also, do you think the surface area of the ankle makes a difference? For example, the knee, you have a broader surface area. As you come below the ankle, the surface area is smaller and the force dissipation is more. Do you think that's a concern?
I think this is one of the problems. I think that is much more concentrated in a small area, and the thickness of the cartilage as well is different compared to the knee, and that probably is one of the reasons why the revision rate is high. But hopefully, with new engineering technology, that can be improved. I don't know. I remember talking to Peter Wood when he designed his mobility. He thought that ankle was the best that it could be done at that point with the technology available. But he always thought that medial pain would be corrected with a different type of ankle, like having an L shape covering the medial malleolus. But it's been done in the past, and that has failed too. So I'm not sure. I think what is certain is that the industry will try and will keep trying to be able to improve that. But you need to look at as well that because there are not that many cases, if you look at the epidemiology compared to knees and hips, there is not that major impact in the industry to be able to produce ankle replacement, because it's not big amount of finance implication there. So I don't know. What's the space?
Thank you, Dr. Ballester. Dr. Ballester, we also joined by Loy. Loy Al-Khatib is an orthopedic surgeon based in Dubai. Loy, welcome to the show, and your questions to Dr. Ballester, please.
Hello, good evening, guys. Thanks again for the comprehensive presentation. So one question, if you do or encounter a patient with advanced knee osteoarthritis at the same time ankle osteoarthritis, which one would you address first? Let's talk about the principles. And would you address the knee joint first and go back to the ankle later on, or what would be your approach?
I think usually always we look at for the proximal joint. So normally I will suggest to do a hip and a knee first. The only time that maybe we'll need to be done the ankle first is if there is a very significant deformity in the ankle. So if you've got a patient with a massive plantar valgus deformity, with the hindfoot significant valgus, I think in this case, unless the knee is as well very deformed, which then you need to assess which one is worse of the two, I would go for the ankle. But generally, I would do the knee first.
Exactly, this is the point. The proximal joints first, this is the message. The other question, if these patients keep asking you about the conversion from whether from fusion to replacement or from replacement to fusion, what do you tell them? Is that possible? Would you advise that? Is that something an option in the near future? Or especially these replacements, they last only 10 to 20 years. So if they want to go to fusion after that, what do you tell them? What should be their expectations?
In my view, I normally go for ankle fusion very, very often. The only time that I will advise to have an ankle replacement are patients, I think inflammatory joint disease is probably a very reasonable option. Patients that they've got significant arthritis in the subtalar joint or any other joints in the hindfoot. But generally, anybody that is very active with no other joints affected, I will suggest that you have an ankle fusion. If you go to the other side, if you have an old elderly person that what you want is to have less trouble than benefit, trouble than complications. I also, if it's possible, unless it's a smoker, etc., I will suggest an ankle fusion, because you do an ankle fusion arthroscopically, they case, they go home the same day, and there is no complications. So I think overall, in my view, multiple joint affection, inflammatory joint disease, yes, arthroplasty is probably good advice. Otherwise, I don't advise ankle arthroplasty, and I think the evidence is there. So that I think it's important to mention that to the patient.
Yeah, I would like to hear. Thanks a lot. One last question. I would like to hear your thoughts on the rehabilitation. Are they similar in terms of time? Would they use 6 weeks of cast followed by 6 weeks in boots, or for both ankles replacement and fusion, or would you have a different rehab protocol for each procedure?
For an ankle fusion, I normally give them 2 weeks in a back slab after the surgery. At 2 weeks is converted to a fixed walker, but I keep them non-weight bearing for 6 weeks, and then weight bearing for another 6 weeks. So a total of a 3 month with a fixed walker, taking the 2 weeks off the back slab. So that's for an ankle fusion. And I do the same for arthroscopic or open.
Oh.
For an ankle replacement, I don't put them in plaster. Probably I'll put them in plaster for 2 weeks just to get the wound settled. And then afterwards, if the wound has healed, I give them a fixed walker, but I tell them to remove it if they want to exercise to get the movement going. Otherwise, they'll get a stiffness. So the main reason to have the boot or the plaster is for the wound to heal, because the wound in the anterior aspect of the ankle, I normally do anterior approach, is sometimes difficult to heal. So that's the main issue.
Right. Well, the last one just got a question asking about your fusion methods. We know that you can do the fusion with a nail, or plate, or screws. Which one do you prefer to fuse? Do you usually prefer to use the nails to fuse the joint, and why?
Sorry, I couldn't hear you well. You were cutting off. I couldn't hear you.
No, what is the implant that is used?
So we have 3 options for.
What are the implants that are used? Is it are you screw based or is it nail based?
What's your preferred?
All right. Okay. Usually I do 3 screws or sometimes 2 screws, 7 millimeters with a compression head. I do nails only for revisions or very deformed multi-joint arthritis, but either if I do open or I do close, I try to put the screws only.
Awesome. Thanks a lot. That was really informative.
Dr. Ballester, I think that's all the questions that we have for this session. Thank you for yet another evidence-based presentation, and we really look forward for another in the future.
Thank you very much. Thanks for your invitation.
Bye-bye.
Thanks.
Bye-bye.